Okay. You know, staging and grading with ultrasound is probably an overstatement. And so I tone it down a little by saying determining the local extent of malignant disease and assessing aggressiveness. It's important because we really probably have gone too far towards breast conserving surgery, and I think we've come back the other way, but then there's a backlash again. So things sort of, you know, the natural pattern of development of things is people get overly enthusiastic, then they get overly pessimistic, and then they get overly enthusiastic but not as much as the first time, and then they get overly pessimistic but not as bad as the first time. So we eventually iterate in on the right amount of treatment. And so we're kind of coming back towards more aggressive treatments, but then you've got the backlash from the Monica Moros, et cetera, of the world. So it's a normal progression. That's the way things always happen in the world. It's really nothing very unique. Multifocal and multicentric disease are more common than previously believed. Local recurrences are really not recurrences in most cases, but unrecognized, untreated residual disease. And we can't blame the surgeon for that. We have to let him know that it's there, and we have to do the best we can to lay out the extent of disease for him, because I still believe surgical extirpation is the best way to treat these things. I have my doubts that chemo and radiation actually ever sterilize the breast. They may stun it, they may slow it down, but I still think it comes back. Obviously, the people who are anti-aggressive surgery really believe in their heart of hearts that chemo and radiation are going to cure these people, so I'm less optimistic about that. I still think the best chance for cure is to get it out surgically. Now, will that always be true? I don't think so. I mean, do we really cure patients? No.